going to lecture on biofeedback EEG and brain entrapment syndrome, which is consistent with being a Democrat. Ellen Saxby is a nurse, registered nurse with background in recovery and chemical dependency training. She also has training in standard biofeedback. She received her education at Hunter College and the Mary Immaculate School of Nursing in New York. Along the way, she had training in EDS, and she's also involved in interactive light therapy. She's fortunate and she's smart because she moved from the east to God's country here. She's presently in Carmel Valley. I'd like to introduce our next speaker, Ellen Saxby. Would you come up, Ellen? Can you put this on? Put that in your pocket.
Very different to be attending this conference, different from the EEG biofeedback workshops, because I've noticed so far that all of the presentations have begun and ended on time, which is very impressive to me. I've been in this area working in the field of biofeedback for about 20 years, and in the last several years I began to notice that there were many people coming through my practice who, in the process of relating their medical history, would share with me that they had been under the care of this mysterious Dr. Arana. And they told me that they owed to his care their health, well-being, their sanity, or their life, or all of the above. And they would always speak in hushed tones of this mysterious Dr. Arana. And it was because they felt that he was not only a healing pioneer, but he is a healing warrior. And all of you who know him know what I mean by that. And it began to happen more and more, and it was only within the last year that I met Dr. Arana. And so when he asked me to make this presentation, I feel very honored to do so, to really basically give a peek at the work of EEG biofeedback and perhaps look at how it interfaces with the world of dentistry and other healing technologies. In Carmel, one of the ways that landlords dramatically raise the price of a house is that you get a peek at the ocean. So this is going to be a peek at EEG biofeedback. In the mid-1930s, Hans Berger and a group of researchers attached sensor to the scalp of a subject and recorded squiggly lines on paper. These lines represented the oscillation of the brain's electrical potential. These impulses were recorded through scalp, muscle, bone, fascia, and cerebrospinal fluid. And a colleague of mine said that is not unlike attaching a stethoscope to the front fender of an automobile and trying to decide what's going on in the engine. However, this was the beginning of EEG, looking at EEG, field of electroencephalography. They looked at these squiggly lines and trying to decipher them, found a burst of fairly coherent-looking activity and circled and said, this must be something, let's call it alpha. And that was really the beginning of encephalography. It has taken a tremendous leap forward since that humble beginning and expanded enormously. We took another leap forward, particularly in the field of EEG biofeedback, when we were able to couple the EEG device with computer technology, so that we now can take this extraordinarily complex brain electrical activity, analyze, reproduce, define, sort, analyze, and so forth, this activity, and do something about it and with it. Those of us who become somewhat fixated with the brain because it's so big and it's so exciting, sort of get, in a sense, stuck with looking into the brain, looking at the brain, and trying to define from the brain activity what is going on in the rest of the body. One of the problems, of course, is that the brain is so big. Years ago, when we began, EEG biofeedback was in its infancy. We could say something fairly intelligent and coherent about EEG biofeedback and make sense to each other. And that's becoming more and more difficult to do. As you know, in physics, there are lumpers and there are splitters. And the people who are in EEG biofeedback are splitting finer and finer and finer hairs, and the field is becoming so complex that every once in a while we do need to jump back and become lumpers and look at, as much as we can, a large picture to try to get some feel for what's going on. My purpose here today is just to define some of the outline of that technology and that specialty. What we do is try to diagnose and treat brain electrical activity. In the process of assessing or diagnosing, the first thing that we do is do a map. We do a look at the whole brain, put sensors across the whole scalp, and ask the computer to put that information in sort of a map format so we can decide what it's about and what it says. There are a lot of processes which in fact do map the brain, and the first, I like lists, and I usually use lists to help to kind of keep a very complex subject somewhat simple. The devices that map the brain, standard EEG, QEEG, which takes a standard EEG and compares it with a 4,000 person database. So it gives it a little bit of a different, deeper information, QEEG topographical map. An EEG map, which is what I do, which is a simpler form of a QEEG, a brain blood flow map, which is really looking at perfusion in the brain, a CAT scan and a PET scan. So the questions that are asked us by the American Psychological Association and the American Medical Association are, do your maps really mean anything as connected to a standard EEG or PET scan, CAT scan? And we're trying to answer that as best we can. Of course, we need, as you do, a couple of $1 million grants to help fund the research that will help answer those questions. So we're looking at, does my map, the kind of simplified map that I do, relate to a QEEG topographical map? Do they give the same information? Does it tell us the same information about EEG slowing, where it is, how serious it is, the level of coherence, and so forth? So the next, thank you so much. The questions we ask about the various kinds of maps are these. Do we get the same information from each of these maps? Are they standardized? Do they tell us the same thing? What can we infer from a map diagnostically? Are they stable over time? Will we get the same information in the morning that we do in the afternoon? Can we create a treatment plan based on these maps? In other words, what if this person is on medication? If they're in allergy season, will it differentiate tremendously? And lastly, and most importantly, can the brain change its own electrical function? And earlier, the neurologist said, absolutely not. There's just no way. This is impossible. It can't be done. But historically, we have some information that's pretty heavy and helpful information. When the first astronauts went up in space, and some of you may know this, have this piece of information, the first astronauts went up in space and they began to have seizures. And NASA said, this is pretty serious stuff. They can't be running those little spaceships if they're having seizures, and we can't give them Dilantin because, as you know, Dilantin blankets the whole brain, and they can't make those microsecond decisions if they're on enough Dilantin to ward off seizures. So they turned to the biofeedback community, and they went to Barry Sturman, who's the high priest of EEG in the biofeedback community. Said, what can you do for us? So Barry began to look at cats, and cats have a very high seizure threshold. Cats don't have seizures readily. And he said, what do cats do that we don't do? And they produce a high amplitude of this 14 hertz frequency. So we began to say, well, if we train the astronauts to produce a lot of this 14 hertz frequency, maybe they won't have seizures in space. And so they did that, and they trained the astronauts to produce this frequency, and sure enough, that reduced or eliminated their seizures in space. And that was really the birth of the technology and the specialty of EEG biofeedback training. At that time, it was in the hands of very few, it was really a sacred cow, and only the very, very highly trained high priests with very, very advanced technology could do this wonderful work. And it was basically done with patients who had intractable seizures. And then they began to notice that these kids that they were treating for seizures did better in school. And those of them who also had a diagnosis of ADD, ADHD began to remediate those symptoms. You say, this is interesting. And if we treat this, we teach the same 14 hertz or this frequency, can we then treat ADD, ADHD? And then they began to notice that the people who were also depressed had less depression and so forth and so on. And so because the brain is so central, of course we know that the heart is central, but the brain is one of the major central organs, that to treat the dysfunctions of the brain may have huge ramifications for a lot of things that are wrong with the person. Excuse me. So the answer is yes, the brain can change its own electrical function. And then of course the next step is then how do we get that to happen? Now just to back up a little bit, the next, let's say next slide, next. There are two major paradigms in, maybe I don't have a slide for this one, sorry. There are two major paradigms in healthcare. It's the professional, what the professional does, and maybe may or may not be there. What the professional does to, for, with, thanks, with or about me. And you may recognize this as I want to point too many fingers, but a lot of, the paradigm in medical care has been, there is someone who knows more than you do and will tell you, give you an order about how to take care of yourself and how to improve your health. The new paradigm is what the professional teaches me to do for myself. And dentistry has really led the way in combining these two paradigms because we do have a need for both. And empowering the individual to increase their ability to take care of their own well-being and their own health. And I find it somewhat interesting that a lot of the people who classify themselves as New Age healers, who do laying out of hands or energy work, really actually fall into that first paradigm. They're people who have a knowledge that the client doesn't have, power that the client doesn't have, sometimes can't explain it to the client how it works and so forth, and are somewhat uncomfortable with the client, asks a lot of questions. So, again, ideally, healing will involve both of these practices. The reason I was drawn to biofeedback is because it has so much to do with the second level. It's so empowering to teach people what makes them tick, how to align themselves with the balancing mechanisms that are hardwired into the physical body and into the brain, and utilize those as much as possible, to the great extent possible. However, as my teacher Lynn Oak says, sometimes if your car falls into a ditch, you've got to call that tow truck. So again, the need for both. In neurophysiology, excuse me, neurofeedback is the art of using technology to mirror back to the brain its own electrical dance, its own posture. And the more clearly and the more real-time that mirroring is, the more potential the brain has to restructure, repattern its dance. I have worked with a couple of patients, clients, who are, the old term was multiple, thanks, Carol. Thank you. The old term was multiple personality disorder, and I believe the new term is, it's got a better term, I don't remember what it is. Anyway, with EEG equipment, you can see that there's a very, very different EEG pattern or signature for each of the multiple personas, each of the alters. And we've also seen that sometimes some of the alters will have diabetes and some will not. Some of the alters will have chronic pain, some will not. And we see the change in the EEG as the alter moves into center stage. And I have seen it with my own eyes, a multiple personality patient, seeing their own kind of gamut of their brainwave signature and getting to a look at for the first time how their brain does the process of creating multiple personas and shifting between actually disease entities and back and forth, into different incredible life zones, and get a handle on it and say, oh, that's how I do it. Oh, I can get better. It's a very dramatic, very powerful experience. And as I said, the brain, the complexity of the brain is somewhat staggering. However, in the process of trying to look at something simple, we sort of get a handle on it. We look basically at the balance between the mechanisms of excitation and inhibition. And it seems to go back again to the yin-yang, looking at, some very simple thing. When one or the other fails to act according to the balance inherent in nature, we see dysregulation. And to use a very sophisticated scientific term, the brain gets stuck. And it gets stuck in postures that it can't seem to get out of on its own. If we take seriously the work of Benoit Mandelbrot, who said that if we look at nature, sometimes we can take extraordinarily complex structures and see them in a very simple configuration, the beginning of fractal geometry. So if we look at yin-yang again, the idea of the excitation and the inhibitory mechanisms of the brain getting stuck, and what I'm doing in my specialty is just helping the brain to get unstuck from that posture. And then the magnificent balancing mechanisms are hardwired into the brain. So all I have to do is kind of like a tow truck, pull the brain back out of that kind of ditch, kind of get stuck in, and then the brain can take over and re-regulate itself. Now, this dysregulation, some of the factors that lead to the condition of dysregulation. The next. Thank you. This is working. I really appreciate this. I usually run back and forth myself, so this is very nice. Thank you. Some of the things that cause this process of dysregulation: closed head trauma, emotional trauma, physical trauma, seasonal dysregulation. We see enormous changes during allergy season. We see people with brains that look like head injury brains during allergy season, and exposure to toxic substances. Of course, everybody in his room is seeing that one way or another. In this one, we're seeing more and more of this as our world becomes more and more chemical and toxic and so forth. Interestingly enough, when I do maps, I can see someone who has had an emotional trauma, and the brainwave patterns can look very, very similar to someone who's had a serious bonk on the head. And I've heard, in the years past, people say, well, it was only emotional, it wasn't real, as though it shouldn't have an impact on the physical body. And so the next transparency, the signs of dysregulation, that dysregulation is in process, some of the things that happen when the brain is out of kilter: cognitive defects, sleep dysregulation, memory impairment, mood imbalance, decreased pain threshold, decreased immunocompetence, and decreased energy. So when the EEG, when the brain gets stuck in these slow frequencies, these are some of the things that happen. Now, this can be very difficult, particularly for someone who is used to being high functioning and used to having their brain just being able to spin out very complex thought processes, used to being in a kind of pleasant mood, aura most of the time, and so forth, and who has even a slight, there's no such thing really, rear-ended or what we call slight concussion, mild concussion, or some kind of mild physical trauma, all of a sudden finding these kinds of problems. It's very, very frustrating. One of the easiest people to treat are people who have serious cognitive defects or any serious dysregulation that looks like this. If they're a person who is used to being very high functioning and has, for example, one bonk on the head, a closed head trauma. We find these people come back very quickly from a single insult, a single injury, again, because the brain is so resilient. However, people who have the next, please, more long-term, lifelong, or congenital problems. Oh, I'm sorry, that's not the one. It says autism, depression. I may not have one for that. If there's, oh no, I probably don't have one for this. Sorry. If you have a situation where there is something that goes back to a genetic predisposition, like autism, family history of depression, chemical dependence, attention deficit disorder, even rage behaviors. Sometimes people who have a head injury or some kind of insult, then if there is a long-term predisposition, then it's much harder to treat. It takes much longer, and there's much more resistance in the brain to restorative processes. Now, I'd like to try to talk a little bit about how I work with EEG, which is a specialty within biofeedback, and the work I do, I work with light, which is a subspecialty within EEG. So just talk a little bit about how we think it works. And as I say, the brain becomes stuck, and if it's insulted, the brain becomes stuck in slow frequency, low frequencies. Like the neurons, instead of having this like a joint that has huge range of motion and has a capacity to do lots of activities, get stuck, and the neurons are firing in very slow frequencies, and lots of neurons are joining in this slow frequency dance, and so that the amplitude or the power is increased. So lots and lots of neurons are vibrating or oscillating very, very slowly. So the brain, therefore, it's like a singer who only has 3 or 4 notes, can't sing a whole lot of songs. And so the brain doesn't seem to be able to have the ability to get out of, in certain cases, out of this stuckness. So what we do after we do the map, which defines as much as we can define what's going on electrically with the brain, we use light, and we put a sensor somewhere on the scalp that defines the dominant frequency of that part of the brain. And then we use light glasses that have LEDs, those little lights. And the dominant frequency of the brain drives the frequency of the LEDs. So in other words, the lights are blinking at the same frequency at whatever site is being measured. And so those lights are frequency specific to certain areas of the brain, and they change second by second depending on how that brain site is changing. So the lights are coming into the visual cortex, again with this very specific frequency that is mirroring the frequency of the dominant frequency of a certain site. But what we do is there's a slight offset. In other words, if the dominant frequency is 4 cycles a second, the lights will blink at 5 or 6 cycles a second. So it's a little bit like massaging a muscle, like coming in close to the frequency, but just a little offset. So it's kind of nudging the neurons or the brain off of that frequency that it's wanting to get stuck at. So the offset goes a little bit faster and then a little bit slower than whatever the dominant frequency is, and it seems to work. We're finding out that it works pretty dramatically and pretty well. That with excuse me, just enough exposure to this light, the brain then learns how to get out of that dysregulated pattern and then re-regulate itself. And what we're finding is that, you know, the therapist regulates the amount of light, the brightness of the light, where to put the light, where to put the sensor, and so forth. And interestingly enough, we keep finding that as we reduce the brightness, the treatment becomes more powerful. As we reduce the amount of exposure, the amount of time, the treatment becomes more powerful. As we space the treatment becomes more powerful, almost a homeopathic kind of approach. And we have made a leap recently, and instead of, we used to put the brightness way up and the person would kind of experience the brightness and then tone it down a little bit so they were just barely visible. And now we put them below the visible level and put black tape over the lights. And it sort of almost moves into California La La Land, because there's almost like one pica level of light stimulation that's reaching the cortex. And recently, one of the researchers has gone a step farther and disconnected the light, so it's just a electromagnetic pulsation that's helping the cortex re-regulate. Excuse me. So, what?
Sorry to interrupt. You start with the brighter lights and then come down. You start with the very low.
What we're finding now is, the question is, do we start with the bright lights and then come down, or do we start with the low lights? What we're finding now is if someone has like chronic fatigue syndrome, long-term, impairment, then we'd never go into the bright lights. If someone who has head injury and is used to high functioning, then we'll sometimes go into the bright lights and then bring them down again. Now the next slide shows the first client I ever treated with this interactive light treatment was a young woman who was in the military, and she had been hit across the head by accident, of course, and was non-functioning on huge amounts of medication. And these are the kinds of symptoms: headache, blurred vision, drowsiness, amnesia, disorientation, slow thinking, distraction, fatigue, irritability, depression, and so forth and so on. And the Army physician had really kind of thrown up his hands and was at his wit's end. And she was a very high-functioning officer, and he wanted to get her back. And she was my first client, and of course I was very concerned about how this would work. And I just put the sensor on the front of her forehead, used just single site, frontal cortex. And so some of the old researchers would throw up their hands and say, "You do what? You can't be measuring EEG at that point." And put the lights very low, 20-minute sessions, and she just sat there and didn't really visually see any lights. But within 15 sessions, she was off medication, back working. It was like one of those miracle cures that you get at the beginning of your practice. And I think this is going to be really a piece of cake. I like this a lot. But we went from there to discovering the complexities of the treatment. And as I say, when the insult is greater, when there is a more serious head injury or stroke, or in situations where there is long-term tendency to a dysregulation, then the treatment becomes more complicated and more complex. The first question that people ask us is, what about blinking lights and seizures? We have discovered that it can function as an anti-seizure medication because the lights aren't strobing at a fixed frequency. We don't use the very bright lights that EEG, that neurologists will use to try to trigger a seizure diagnostically. And the frequency is changing constantly. So it's kind of, in a sense, working the cortex and allowing the cortex a greater variability and a greater flexibility. So it really functions very often as an anti-seizure treatment. In situations that are degenerative, like Parkinson's, multiple sclerosis, those kinds of disorders, this can be very effective in ameliorating some of the side effects and some of the difficulty of those disorders. It doesn't ever totally, so far, we have not seen it completely stop the flow of those degenerative processes. It's very exciting in childhood autism. We're seeing, and we have Len Oaks, who works up in Walnut Creek, has people flying in from all over the country, all over the world, with treatment for childhood autism. One of the most exciting things that we're seeing is treatment of rage behaviors, violent behaviors. Of course, that's a huge area, and I'm again just touching on some of these things. It's very interesting how often people will acknowledge that rage behaviors, violent behaviors, can be connected to closed head injury, history of closed head injury, as well as a history of abuse. So that you get emotional trauma, physiological trauma to the brain, and what we believe is those breaks on the limbic system that may be connected into the frontal cortex simply don't function either at all or don't function very well. And so it's very promising, some of the treatment of closed head injury. Now I'd like to show you some of the maps, to give you a look at what they look like. Yeah, that's
not a map of Carmel Valley.
That's Carmel Valley as you go out toward Kashawa. Just briefly, some of these will be in color, so you can get, these are just a black and white one. But what the the program does is take a look at, the top one is the delta, the most severe kind of EEG slowing. And it takes the 21 brain sites that we look at and orders them to the site of the most slowing to the site of the least slowing. And this EEG slowing is sort of like static in the radio. When you turn on the radio, if there's a lot of static, the signal signal is not clear. If there's a lot of EEG slowing, if there's a lot of height in those bar graphs, then there's a lot of static, and that usually correlates to severe or semi-severe problems. And you can see the third one down is the alpha, and the alpha slowing can be very hard to treat, very often correlated to long-term depression, fuzziness, not clear thinking, and sometimes those symptoms that are just, that you really don't get treated for, but they just know that they're not functioning optimally. So we'll take a look at some of these maps. Would you come to the EEG Biofeedback Convention in
Yeah, as long as you work me up first.
Okay.
I need this.
Well, actually, no. A lot of people ask me, who benefit by this, and nobody's brain functions optimally. After I broke my arm, my map looked like a close-head injury, even though I did not hit my head. And I had a lot of those symptoms of, cognitive effects, memory impairment, and so forth. Okay, this is a severe attention deficit disorder in an adult. This is an adult who has a very difficult time getting, holding, managing jobs. And this is a map, this is before treatment. And there you can see, this one is the color. And so you can see, when you see a lot of one color, there's also a lot of coherence. And coherence, besides the EEG slowing, is a big problem. Coherence is like, if you think of a three-legged race, when you get, two of the legs tied together, the person usually takes a couple of steps and falls over. Well, when you get a lot of centers in the brain that are coherent or hypercoherent, they're locked together in phase, then you have a lot of these cognitive difficulties, because the brain needs to be able to be like a dance troupe that can dance together, or everybody can go in different directions to multitask. And so very often you get a brain like this, cannot multitask, and you get a lot of cognitive problems. And the next, yeah.
What are the colors mean? I don't understand how that graph is.
Okay, this you can see on the this color code to the right, and it usually has to do with amount or amplitude of slowing. And so when you get into major slowing, you'll see that in the front, on the top there, some white or red. And now, in this map and a QEEG map, which is a little bit more sophisticated than this, sometimes, you can pick out areas that have not been seen in other diagnostic testing. For example, we had a case of a woman who was complaining for 2 years she claimed that she had fallen in Safeway and she had hurt her head, and she had this impairment and this head pain. Oh, thank you. Thanks. Oh, great. Cool. And it didn't show up on standard diagnostic EEG. It didn't show up on anything else. And finally, they did a Q, and the little red dot showed up exactly where she said it hurts over here, and she just burst into tears because it was able to define something that was very hard to define diagnostically. So that's what we're seeing. Again, the color code is over here, and it depends on how we set it up. Green is probably about 7 or 8 microvolts. And then when we get areas of white and red, that's really where the problem areas are. And the next one, just kind of look at a few of these. And again, not as much severe slowing, but over a lot of areas of the cortex. Now, Len Oakes is the man who developed this process, and he has done an enormous amount of work with this. And he can look at a map like this and say, I think there's an infection, maybe look for something like Lyme disease or something. I'm not at that level of skill, so I, fortunately use Len's wizardry. But this is, again, see a few areas here. Now, interestingly enough, this one correlates to, and I see this more and more frequently, I haven't had that, my N is fairly small, or 6 or 7, but slowing right at this point correlated with eating disorders. And you see only a few areas that are really high, and it's on the right central cortex.
Would you have specific areas for an alcoholic, for example, or a drug addict?
Sometimes with alcohol or drug addiction, we see huge alpha. Alpha is down here. The graph for alpha is down here. We would see alpha over large areas of the frontal cortex. But again, we rarely see pure alcoholism anymore. It's usually cross addiction and multiple diagnosis. And this one, you see one area. This is close-head injury, and you see one area with this huge amount of slowing, with severe deficits, in particular memory and mood, right cortex. And next one. Okay, I want to go into a case study here. So, and again, to help to define how my work interfaces with other therapies. This is a client who came with a very difficult time getting a diagnosis. And finally, they called it fibromyalgia, which is, it took 2 years for them to come to this diagnosis. And what her symptoms were the paniculitis, fatigue, GI upset, soft tissue pain, left ankle pain and swelling, insomnia, and emotional reactivity and fear. And this was one of my clients who had seen Dr. Arana for the removal of the mercury. And the possible contributing factors in her problem: early childhood traumatic stress, close-head injury, and the removal were long-term presentation of mercury amalgam and then removal of those. And after she had done the successful work with Dr. Arana, which she had said changed her life, then she had a severe close-head injury. And so she found herself back in the situation where she had all of these symptoms. And what we usually see is on the symptoms pre-treatment, we scale them on a scale of 1 to 4, 4 being severely interfere with life. And so a lot of her symptoms, as you can see, were in the scale of 4. She was really suffering a great deal when she came in after this really severe closed-head trauma. Now, can I show you her first map?
Can you tell us what the trauma she received?
The closed-head trauma? She had been swimming and had hit her head full bore up against the side of the swimming pool. Whole crown smacked right up. And she was unconscious for 3 or 4 minutes, headaches, and then, no treatment. The doctor said, well, you're okay now, and all the neurological signs are okay, so everything's back to normal and you're all right. However, this is what her map looked like. And this is one of the old maps, the way they used to look, and severe EEG slowing. And this was maybe 4 months after she hurt her head, and the symptoms had just kind of flared up, and it kept saying it's on your head, it's your emotional, whatever. So I saw this severe EEG slowing. So we did probably 3-4 months of treatment, and then the next map, I'll show you what that looks like. Thank you. And so we can see here that she's a lot better, which correlated with her subjective report of her treatment, of her symptoms rather, and yet still you can see when the delta, the amplitude, or the power in the delta goes down, sometimes you'll see the power in alpha go up. And that can be a more difficult part of the treatment, so there was still more work to be done, and we kept going. In the next, thank you. So this is where she was close to the end of treatment. This wasn't quite finished, but this was almost all of the work done. And you can see a lot of coherence, and again, that stuckness. Very often we see this when there's an emotional piece of work that has to be done. This client, as I said, had a lot of emotional or early childhood abuse, and sometimes we see that surface as the brain is rewiring, reframing, repatterning its dance. There's sometimes old work on the emotional level that comes up to be finished and completed, and that's what happened at this phase of the treatment, and she was willing to do some good therapy and counseling and get back. And I don't have her most recent map, but her most recent map is all of the, it looks like the 4th level down. All of the bar graph is pretty much flat, again, which correlates very nicely with the almost complete cessation of her symptoms. Her energy level is up, she's back high functioning, emotionally balanced, and so forth and so on. So this is, again, I hope a comprehensive look at a very complex piece of question here.
Have you ever worked in conjunction with the cranial osteopath and
Oh.
mapped afterwards? Have you done that?
Oh, yes, the question is, have I worked with a cranial osteopath and done MAP? One of the things that other therapists have asked me to do, which is a very exciting piece of my work, is do pre and post mapping for other therapists. And I'm sorry, didn't think to bring that. I'm sorry, but I do have some pre and post maps from cranial therapy, and it's extraordinary. It's beautiful to see, with sometimes 1 or 2 treatments, the changes in the whole brain. Neurotherapy, I'm not sure what. Neural.
Injections of local anesthetic around the scalp or into the points of trauma, that
Oh.
kind of thing.
Okay, I haven't mapped that pre and post. One of the other things I've mapped pre and post is EMDR. And see dramatic brain changes in 1 or 2 sessions of EMDR. That's it's eye movement desensitization and release.
What is that, EMDR?
EMDR is eye movement desensitization and release. And it's a very powerful treatment, and I have, so a lot of other therapists are asking me to do maps, again, pre and post what they do to document that there are very, very powerful brain changes. And one of the exciting things about living in this time and working in this time is that there are so many roads to that same healing. And I guess what everybody's looking for is the maybe the easiest, the best, the quietest, the most gentle road to that place of homeostatic balance. And I like that list that was presented earlier. I think it's love, fulfillment, excitement, and grace. So I don't know if I got that list right, but ideally, I guess that's where we all want to go, where our balance brings us. And as I say, the dovetailing and the working together with other professionals is one of the most exciting parts of being involved in a conference like this. No one person can know, I have trouble knowing EEG biofeedback, effectively enough, far less knowing other people's specialties. And as you're probably finding, clients are very often finding their own way to the various therapists that they need to see. But also a conference such as this allows that beautiful kind of cross-referencing and cross-validating other people's healing modalities.
Do you have the opportunity to do a patient, let's say, prior to mercury filling removal, and then to repeat it after the mercury fillings?
The question is, have I done a mapping prior to the removal of mercury fillings and then after? No, but that's one of the projects that I'd like to do. I'm sure there's got to be dramatic changes.
Is this technology that you use, is it available? I mean, could we use it in our offices and maybe send you the chart for evaluation?
The technology to map?
Map a patient that we have.
The technology, I believe, now costs about $7,000. And one of the things that Lennox is, of course, working at is bringing that cost down so that the technology gets out there and is used more widely. And so that's one of the things that we're hoping to see, that someone who could map, again, not only to define, what needs to be done in terms of biofeedback, but to help the pre and post treatment definition. Another question?
When you have a patient who is mapped, if they do a mapping in Phoenix, Arizona, and one in New York, and one in California, would they be consistent? Is it a standard procedure, or is it going to be operator sensitive?
That's why I presented in the beginning that, are these maps standard, and how standard are they? There is a very close correlation between the QEEG, the maps that I do, the topographical brain, the blood flow maps and so forth. Very, very close. However, some people's maps are standard over time, and some people's are not.
I just meant
So,
technique sense.
in terms of technique, We're close, it's close. They're not identical, and that's one of the questions that gets asked. Now I have the EDS equipment. Someone who does an EDS map in New York, if they come to me, then that map I use their map. So anyone who's using this particular piece of technology, and I think there are probably 25 of us worldwide. So we can interchange maps, absolutely. If the patient herself or himself is stable over time.
What kind of costs are there? What are the costs for
The cost to the patient? Usually $100 for the map, $50 for a session. And hopefully, again, there are 3 levels in terms of treatment. One is, the one single insult, someone who's been high functioning. We look at 15 to 20 treatments. Someone who has a more serious injury with predisposing factors, maybe 30, 40 treatments, and then someone with serious injury with long-term history, multiple factors, we look at 60, even more, 80 treatments. One of the things that Len Oaks is encouraging people who need long-term treatment is to buy the equipment, and he trains them to treat only themselves.
You don't have any pictures of your equipment, do you, or slide or anything?
No, I don't, but basically what it looks like, you've also probably seen those dark glasses with the LEDs, and the patient puts on the dark glasses, and the sensor goes here, and then it just looks like a computer. So that's, and what I'm getting in the next 2 weeks is a laptop, so I'm very excited. I will be portable. So the patient comes in, sits with the dark glasses on, sits with their feet up for 20 minutes, and doesn't see anything, doesn't feel anything, and goes home. Very often feels something within half an hour to an hour later, and then, or even within the next few days.
Do you have any comments about light therapy, the glasses, it looks like?
Yeah, the battery operated, prepackaged. There's a lot of controversy that's raging around those. Some of the studies are very, very impressive. Some of of course, the companies that make and sell those do the studies and publish the studies. Most of the people in the field are very, very cautious around the use of those. Because the companies, and I have had people that I've treated with my interactive light and go out, looking really, the map is perfect, really everything's flat, symptoms are down, and they go buy one of those machines saying more is better, and come back and the map is really kind of askew again. So I'm very cautious. In the back is a question.
And do you do a lot of counseling around the session, or do they have a lot of emotional releases when they're on the glasses, or is it pretty quiet?
There can be a lot of emotional release that happens, particularly again in people who have, like, for example, long-term depression, or have an unconscious trauma that they've been avoiding for a long time. And what happens, we usually see people feel better, pretty quickly, and then that's sort of like a warning red flag for me. And then sometimes we'll see they get very agitated, very upset, can't sleep, and that's the key for the need for real serious counseling / or therapy, because it can bring up unconscious stuff. Question in the back?
Are there people you would not refer? People who you think would not do well with this technique?
People who would not do well with the technique. People who I'm very cautious around, people who have a seizure disorder and are being treated with medication for seizure disorder. People of any kind of visual problem, detached retina. I was asked to treat a patient recently who had just finished being rolfed. And so I did a map, and her map was perfectly flat. I mean, it was the cleanest map I've ever seen. And she felt that she had a history of early childhood abuse, and she just thought there might be some unfinished business there. And I just said, I don't think there's anything I have for you. So those are the ones that jump to my mind right now.
Have you done pre and post rolfing?
Yes,
What
yeah.
kind is my son is a rolfer, that's why I asked.
Well, that's the same thing. Is a lot of EEG slowing, pre-rolfing, and then post is just beautiful, really sweet. Everything looks, the cortex certainly looks real clear.
Does this have any benefit for Tourette syndrome?
Yes. And a lot of people are looking at Tourette's as being sort of an umbrella under which a lot of the other categories like ADHD, chemical dependency, behavior disorder, rage behaviors fall. And yes, we're seeing very nice changes with Tourette's. Yeah.
One more, are you familiar with the Vegasome machine?
Vegasome machine? No, I don't know.
I was wondering if you used it first and mapped after.
Well-
It changes the frequencies.
Well, one of the things that's mind-boggling, there's so many exciting technologies that are tremendously effective in changing the way the brain dances. But I don't know about this one.
We hear and read about things like eating disorders and depression and chemical dependency being related to serotonin.
Right.
And do you find, or has anybody looked at serotonin levels
Yes.
and this process?
One of the things that when I say we know, we sort of know, we think we know, maybe we know, is that the chemistry of the brain and the electricity of the brain, in a sense, drive each other. So we think that if you change the electrical posture of the brain, then you're going to have some effect on the chemistry, brain chemistry. Now, it seems as though many of the brain chemicals are manufactured and distributed throughout the brain in very specific frequency bands. In other words, the brain needs a certain amount of 4 hertz frequency to manufacture and distribute certain chemicals. The brain needs 7 hertz frequencies and so forth. And so that's one of the other reasons why it's so important that the brain is free to range, again, that range of motion concept, through the frequency bands very freely for the appropriate manufacture and distribution of these chemicals, particularly serotonin, dopamine, and the serotonin-dopamine mix, which is so critical in mood disorders and so many other mental processes, emotional processes.
Is that anybody with senility and or known Alzheimer's?
There's some benefit for Alzheimer's, and it depends on the senility. There are types of senility. And again, it doesn't seem to completely correct, but it can slow down some of those degenerative disorders and give temporary improvement.
I just wanted to comment on that question. Like, I did a study with Norm Shealy about 10 years ago on the Lumatron, like stimulation to the eyes, and we measured the neurotransmitters in the spinal fluid, and all of them are altered by dopamine, serotonin, all of the ones known at the time were greatly altered by light stimulation.
Well, the Lumatron, the people who use the Lumatron get very, similar results. I mean, and I think the treatments of the future are treatment of light and sound is where we're going. And Norm Shealy is one of the all-time great pioneers of, using sound and light and, yeah.
Have you done anything, quote, unquote, simple, like giving somebody who's depressed magnesium and doing them before and after? Because one of Dr. Shealy's findings is that everybody who's depressed is magnesium deficient.
Well, everybody who walks in my office, my first statement is, are you on minerals? Are you on a good mineral supplement? And I have discharged a lot of people from my practice after they get on colloidal minerals, and it's kind of tempting. A lot of times they come back the second week and say, gee, my blood pressure's down, and so forth, I'm feeling so much better. This is great biofeedback, and I'd love to take the credit, but very often it is mineral supplements when they get that quick a result. Absolutely.
Is the electrical current that's created by all the metals that we put in the mouth, does it have any effect upon the EEG or the wave frequency of the brain, or is that too far away?
I can only guess. I would guess that it probably does, but I don't have any data to really support that. When you say it's too far away, it's probably one of the ways that we think that consciousness works, because they still haven't been able to define how the brain produces consciousness, except for the concept that there are these microtubules, that every cell in the brain is connected to every other cell in the brain and connected to every cell in the body. So in a way, there's probably no such thing as too far away. I don't know.
A lot of us in here do kinesiology muscle testing.
Mm-hmm.
And I was wondering if you were to wire somebody up and get patterns like you have, and then introduce, for example, a vial of DMPS into that patient's neural field where you have an auricular cardiac reflex, would you see changes instantly on that?
One of the things that we're working toward is getting a map that's a moving map. You know, that we can set up 21 sensors and watch the brain changes as we introduce different processes, different toxic substances and so on, and remove toxic substances. So we're still about maybe a year away from that technology, but I'm sure that's what we're going to see. Yeah.
I'd like to comment on that last question because we've done that.
Oh, great.
We checked on EEG biofeedback with EAB and muscle testing. And the interesting thing was that we did brain mapping. And the brain mapping didn't change on the patient, but it changed on the practitioner.
Wow.
Yeah. So everybody who's looked in the field in AK and started to study the patient, they all looked at the wrong person.
That's extraordinary.
But the changes were very dramatic on the practitioner.
I hope everybody heard that. That's the changes in the practitioner.
Do you have a number for your office and the name of your facility?
I just moved my office to Carmel, beautiful downtown Carmel Valley. So I'll give that to you. I'm still kind of in process, so I can give it.
Did you bring any cards with you?
I did not bring any cards with me. I apologize for that again. In flux here.
Would you give us your phone number?
Yes. My name is Ellen Saxby, and I'm in the book. Actually, the Biofeedback Center is still in the book, and the old number that was in the book, 625-6373, will be transferred. I don't know whether they give the information of my new number. My new number is 659-3106. That's my Carmel Valley number. 3106, yes. And those of you who are in kind of new technologies and new therapies understand how, and of course some of the discussion this morning was on the politics of that, and of course I don't want to go into that area, but you know how difficult it is to bring something new into an area. Carmel is a interesting area to try to introduce something new in, and that's why I admire Dr. Arana and his work so much. In fact, last night someone was speaking about the Academy of Biological Dentistry, and she said to me, "Do you know that it's right here in Carmel Valley?" So I said, "Wow, interesting. I know a little bit about it." And one more question back there?
Have you ever seen any results with people with rashes and hives as far as being able to alter the frequency of their outbreaks or anything like that?
I'm sorry, people with...
Please text and I translate. Rashes and hives. Skin rashes.
Well, what I see is that as people balance the cortex, then those either disappear or much dramatically reduced. Okay, thank you.
Thank you. Very good.
Thanks very much.
That's very interesting. I'm going to take the microphone. Fascinating stuff. Great. Thank you, Ellen, for the wonderful material. That's fascinating. We are scheduled for a lunch break, but I think we have some announcements to make. Do you have something to say? That's a loaded question.
This is 6